So the reason they put me last is I'm the goofiest. So we're going to talk briefly about some arthritis and hip and knee replacements and some advancements in that. But Sean, I think I've got beat. I've had 15 orthopedic surgeries on me. 15. I got to tell you guys something. I figured out with surgery, there is no question it is better to give than to receive. There is no question about that. So we all know what a joint is, and Adam, I'm not talking about that kind of joint, but we all know what a joint is, right? It's where two bones come together and they move. Well, we've all seen the end of a chicken bone. You know that white stuff that covers the ends of the bones? We call that cartilage. And cartilage is the slippery, smooth stuff that covers the ends of bones so they can move past one another so smoothly. All arthritis is, all it is when that cartilage wears away. Now, this is a picture, and I'm going to use laser point up here, but this is a normal knee right here. And you can see that the end of the femur right there is nice and white and smooth. That's a normal knee. That's what it should look like. The middle one, you see it starts to look rough. That's because the cartilage is wearing away. And that's all arthritis is ultimately is when the cartilage wears away. And the picture on the right, that yellow looking stuff, now let's go back. This yellow looking stuff right here is bone. The cartilage is worn away to the point there is none. And you have one bone rubbing on another bone. That hurts. How many of us in the room have arthritis? Yeah, did you know that if you live long enough, you get arthritis somewhere? Everybody who lives long enough gets arthritis somewhere. And here's an example of what a normal knee looks like on your left. And if you see the space between the two bones, that's the cartilage. The cartilage doesn't show up on x-ray. If you look at that x-ray on the right, look in the middle part there. Well, we call this the medial side of the knee. And for some reason, I keep it. This is bone on bone right there. That cartilage is completely worn away. Does everybody see that? That's what arthritis looks like on x-ray. Now, if you look at a hip joint, the hip on the left the hip is a ball and socket. And do you see the space between the ball and the socket on that x-ray on the left? Compare that to the x-ray on the right, where you can see the bone of the ball touching the bone of the socket. That's because all that cartilage is worn away, and they're now bone on bone. And that hurts. So there are over 100 different causes of arthritis. We tend to divide them into two main categories: the wear and tear arthritis, osteoarthritis, degenerative joint disease. That is the one that the majority of people get. There's a smaller category in terms of number of people called inflammatory arthritis. But if you have one of those, you really want to see a rheumatologist. And I think if there's one point I would make from my talk is if you have arthritis, see a physician so they can tell you what type of arthritis you have. Because the treatment, if you have an inflammatory arthritis, is totally different than if you have wear and tear arthritis. And it's really important to know that difference. Okay? Now, again, it's not all wear and tear. And so how do we figure out what type of arthritis you have? Well, we say we're going to take a history. And that means we ask you a bunch of questions. We examine you. We'll get x-rays. And sometimes we'll get some lab tests. But it's important to know what type of arthritis you have. We all know if you have arthritis, it hurts, right? And your joint, whatever joint it is, whether it's a finger or a knee or a hip, it doesn't work as well, and it doesn't move as well. Joints that have arthritis lose motion with time. And when someone comes to see us who has arthritis, we try to figure out, how are we going to help you? And I tend to divide it into non-surgical options and surgical options. Here's a list of all the non-surgical options. Now, because of time, we can't go through all of these, but we've all tried Tylenol and anti-inflammatories and capsaicin creams, braces depending on the joint. You can use a cane, crutches, or a walker. Physical therapy can help. Injections we've talked about, and alternative therapies. Jeff just talked about one, the RFA treatment. I was shocked that it didn't make a difference in the knee, for the total knee. I just heard this, is the first time I've heard this. But RFA, we just found out, works for knee arthritis. So there are many different non-operative things that can be done to treat arthritis. Now, eventually, though, you get to the point like this guy, where here the pharmacist is telling him, take 1 capsule tonight, and if there's no improvement by tomorrow morning, take the whole bottle. Okay, well, I would not recommend that no matter what the medication is, all right? So how do you decide if it's time to go see an orthopedic surgeon? Well, it's not like where this one doc is saying to the other one, I explained the risks to his wife, and she thinks we should go for it. That's not when you come to see us. So when you see one of us is if you have a knee especially that has recurrent swelling in it. So swelling is a sign of a problem. If you have fluid in the knee, it shouldn't be there. Something's wrong. If you have pain that's limiting your ability to do activities that you want to do, if it's waking you up at night, and then if you have difficulty doing, we call them activities of daily living. That's being able to put on your own shoes and socks, go up and down stairs, be able to even walk to a store. If you're having problems with those things, then it's time to see somebody. And this is that same picture of the gentleman who's bone on the inside of his knee that you can see there. So what do we do? If you've got hip or knee arthritis, it's bone on bone. Well, we talk about doing a joint replacement. The $5 name for that is an arthroplasty. And this is a side view of a total knee that I did about 20 years ago. The kneecap is right here in the front. Now I keep doing that. The kneecap is right here in the front. Metal on the end of the femur thigh bone, metal on top of and into the tibial leg bone. There's plastic in between. That's what an actual total knee replacement looks like from the side. We also can do partial knee replacements. So if you have arthritis in just one part of your knee, we potentially can just replace that part of the knee as long as the other parts of the knee are in good shape. And the $5 name for that is a unicondylar knee replacement. I tend to say partial because it's easier to say partial. And this is what an x-ray of one looks like right here. Metal on top of and into the tibial leg bone, metal on the end of the femur thigh bone. There's actually plastic in between there. Okay? Here's a front view of a total knee. So people, I'm pretty sure people think total knee replacement, we whack out from here to here. We don't. Even in a total knee replacement, we only take off about 1/4 to 3/8 of an inch off the end of the bone. It's truly a resurfacing procedure. But in a total knee, we would put a piece of metal and plastic on top of the entire and into the top of the entire tibial leg bone, metal on the end of the entire femur thigh bone, and plastic goes in between in a total knee. Okay, this is an x-ray of what it actually looks like from the front. Now what about a hip? So in the hip, we talk about a total hip replacement. And in the hip replacement, we only take out the bony ball, and we put in a rough metal socket, rough metal so bone grows into it. Inside of that is a plastic liner. A ceramic ball attached to a metal stem is the word we use in the hollow tube of the bone. You know how bones are hollow tubes? We put a stem in the hollow tube of the bone, and that allows us to get fixation to the bone, and then we can put the ceramic ball onto that. And this is an x-ray of an actual hip replacement. Now, something that I'm enamored with now is the Mako robot. And I want to say right off the bat, I'm pretty sure if you ask 10 different orthopedic surgeons their opinion about something, you get 11 different answers. Okay? So there are many different ways to do things, and we're lucky because most of them actually do pretty well, at least in my little world of hip and knee replacements. And this is something I'm really enamored with right now. I will tell you, there is no question, there is nothing wrong with having a hip or knee replacement done without the robot. I want to be very clear about that. There's nothing wrong with it. I just happen to love this thing. And the Mako robot has been out now for quite a long time, actually, for doing partial knee replacements, and a little bit longer for total hip replacements. And about 2.5 years ago, actually the first total knee replacement was done, I believe, in July of 2016 is when the first one was done. And I love this thing. I really like it, and it's not just a robot though. It allows us to plan the surgery for every single person individually in 3 dimensions, and we can do that before we do the surgery. We can modify it during the surgery, and then the robot helps us carry out the plan. But to me, the big deal about Mako is it allows me to get the perfect plan individualized for any single person. And then the robotic arm helps me carry out that plan. So what do I mean by the plan? Here's a picture on the left. This is the plan for a partial knee replacement. We're going to replace just the inside of that knee right there. Here on the right is the plan for a total knee replacement. The green is supposed to mimic the parts we're going to put in. And so we get a CT scan of every person we're going to do it on, and it's their actual hip or knee. And we plan the surgery before we do it. And then during the surgery, because we have to take into account the ligaments and tendons, we can adjust that plan until we get it just right for any given person. And then the robotic arm helps us carry out that plan. So here's what it looks like in a hip. So this is planning a left hip replacement. You can sort of see the artificial ball, the socket, the stem. And again, it allows us to do the planning. To me, that's the big deal of this, is the ability to get the perfect plan. And the robot helps us carry out the plan. Now, this is an actual picture on the right of the robot. It's not the lost in space guy waving his arms all around. It's about as big as a dishwasher, and then it has an arm that comes out of it. And at the end of the arm, we can put a burr, a saw, or a reamer, and it helps us carry out our plan. But this is what it looks like, okay? Now, one thing to remember is hip and knee replacements are considered 2 of the most successful surgeries known to mankind. And here, these 2 therapists are saying to each other, wow, that's what I call a successful hip replacement operation. Now, I don't let my patients do this till the 2nd day after surgery, okay? Please don't ever do this if you have hip replacement. But hip and knee replacements have a very high success rate. Nothing is perfect, but hip and knee replacements are very successful. And how do we decide as surgeons what to do for someone when they come to see us with hip or knee arthritis? I call it who, what, where, why, when, how, and expectations. And the cartoonist remind me, also look at x-rays. So here the doc is saying to this gentleman, I have to x-ray your arm again, this one is a little overexposed. So x-rays are also important. Well, what do I mean by the who, what, where, why, how? And we're actually coming in for a landing here. So when I talk about who, I'm talking about how old is someone, what's their lifestyle, what's their occupation. Because the options for arthritis that we would consider for a 25-year-old are totally different than what we would consider for a 75-year-old. What about what? Well, I want to know what the chief complaint is. What do I mean by that? Well, someone comes to me and says, dude, my knee hurts 25, when I've run 15 miles, I'm concerned about totally different things than the person who comes to me and says, I can barely walk around my own house. Those are 2 completely different problems. Where is which joint? So we have different options in the knee than we do in the hip. We can do a partial knee replacement. We can't do that in the hip. When? So again, the problem when it occurs is totally different if it's waking you up at night and you're having a hard time walking to the store compared if it bothers you 10 miles into your run. So, and why? This is where I'm going to go back to I talked about earlier. What type of arthritis do you have? And that's why it's so important. If you do have arthritis, you want to see someone to make sure you don't have one of these inflammatory types of arthritis. And then how does it affect your function? What is it you can or can't do? Classic thing for hip arthritis is people struggle to put on their own shoes and socks. Okay? So the other thing that's important is realistic expectations. This is my expectations cartoon. Here this gentleman's wife is saying, you must have run a mile this time, you've been gone 4 minutes. Well, I think his expectations are different than hers. And it's really important whenever you have any surgery, really, to have realistic expectations. One of my lines that I tell everyone is that I can't make you 16 again. We can't do that. But we want to make you better. And that's to bring this full circle to what Sean so nicely told us right to start off with. The purpose of IORI is to keep us all moving and to get us better. And we can only do that with research.